So today's topic is routine antenatal care. So can anybody tell why it is important? So what should be the ultimate goal of antenatal care? What is antenatal? Antenatal means pregnant woman. So ultimate goal of antenatal care, prenatal care is to have a healthy mother and healthy newborn at the end of the pregnancy. So it will consist of history taking, examination and various investigations, so that we should timely detect a high risk factor and we can optimize some pre-existing medical problem of a woman. So ultimately we can have a healthy mother and healthy newborn at the end. So prenatal care or antenatal care, it is a systematic supervision, that is examination and advice of a woman during pregnancy, and the supervision should be regular and periodic in nature according to the need of the individual. So the follow up, it is regular and it depends on individual woman. Some women or some patient may need frequent follow up. Can you tell me what patients, what type of patient may need? Do you know some high risk woman or high risk factor in pregnancy? Yes? Yes. So pre-existing hypertension, chronic hypertension, pregnancy induced hypertension, women with known diabetes, women with anemia or some genetic problem. So all these women, and some pregnancy associated complications like twin pregnancy, triplet pregnancy. So there are many conditions in which women may need frequent follow up. So actually prenatal care is the care in continuum that starts before pregnancy and ends at delivery and the postpartum period. So this care, prenatal care, ideally it should not stop just after the delivery. It is continued after the postpartum period also for a few weeks. What is the period of puerperia? Till 6 weeks after delivery. So that period consists of 6 weeks after delivery, and the care or the follow up, regular visit should be continued after delivery also. And antenatal care comprises of careful history taking and examination. Examination is general and obstetric, that is specific to the pregnancy. Do you know what is general examination? What is general examination? The examination of vital parameters, examination of pallar, icterus, systemic examination, examination of various systems like cardiovascular, central nervous system. So, and then obstetric, that is specific to the pregnancy. And the other important thing is advice which is given to the pregnant woman. So the aims and objective of prenatal care or antenatal care are to screen the high risk cases. So some women may not know about their problems, may not know about their medical condition, and some women may be high risk when they become pregnant. Okay, they are in women with heart disease, suppose. So they are comfortable, they are going through their life comfortably, but pregnancy may superimpose or pregnancy may predispose such women for some complications. So pregnancy can deteriorate further these conditions. So to detect high risk cases is aim and objective. to prevent or detect and treat at the earliest any complication. So if women have some complications like threatened preterm labor, preeclampsia, so we have to detect these conditions timely and to prevent its complications, to ensure continued risk assessment and to provide ongoing primary preventive health care, to educate the mother about physiology of pregnancy and labor by demonstrations, charts and diagrams, so that fear is removed and the psychology is improved. So along with the examination history, the counseling of the woman related to the labor, related to the pregnancy is important. Why counseling is important? We have to counsel the patient. Suppose she is a twin pregnancy, so we have to counsel that what can be the complication which are specific to this type of pregnancy. She may need to visit frequently, there is risk of anemia, there is risk of preterm labor, and if she is a known preeclampsia or hypertension, then what complications can occur during pregnancy? What can be the cost of such pregnancy? Cost of a diabetic woman who is pregnant. She may need to shift to insulin and she may need some extra investigations. So all that. So counseling about labor is also important, especially in primea gravida. They don't know about the labor, how labor happens and what she can predict. So she can ask some questions, and counseling is important so that fear is removed and psychology of the woman will be improved. Also to discuss with the couple about the place, time, mode of delivery provisionally and care of the newborn. So that is also important, about the time of delivery and sometime mode of delivery. What are the modes of delivery? What do you mean by mode of delivery? Mode of delivery may be vaginal delivery. Delivery, other mode is by cesarean section. So only two modes of delivery, by vaginal delivery or by cesarean section. So some women may need a repeat cesarean only, or may be a candidate for cesarean section only. Suppose she is having placenta previa. Placenta previa is a condition when there is placement of placenta or implantation of the placenta in the lower segment. Sometimes it is a major type of placenta previa which covers the internal os. So she cannot have, or she should not have, a vaginal delivery. It can be life threatening to the woman. So such women may need a cesarean section only. So discussion regarding all the decisions related to the mode of delivery. To motivate the couple about the need of family planning. So family planning advice should start during pregnancy as well, not after delivery. The mind making of a couple or the counseling, awareness regarding the family planning method, it should be discussed during pregnancy. It is the, ideally it is the right time to discuss this type of thing. And also appropriate advice to couples seeking medical termination of pregnancy. The objective is to ensure a normal pregnancy with delivery of a healthy baby from a healthy mother. Now we can discuss few things according to their visits. So if some woman comes to you at the first visit, so at first visit our aim should be to assess the health status of the mother, whether she is healthy, not only physically, she should be mentally, she should be stable. Health status of the fetus. How you can know the health status of fetus? By some important test like ultrasound. We can know the health status of the fetus. To assess the fetal gestational age and to obtain baseline investigation. So appropriate fetal gestational age is calculated. How it is calculated? Gestational age. What is LMP? Last menstrual period. So we calculate period of gestation with the help of last menstrual period. What we calculate? On the very first visit, we write LMP of a woman, that is last menstrual period, and we calculate the EDD, that is expected date of delivery. With the help of LMP, we calculate EDD. And how it is calculated? You people must be knowing already. Yes, 9 months and 7 days. So 9 months from the first day of the last menstrual period. So 9 months from first day of last menstrual period plus 7 days is EDD. So whole pregnancy, it consists of how many weeks? Total of, till EDD, it is 40 weeks. A complete pregnancy or a term period of gestation till the EDD is 40 weeks. So that is calculated during the first visit, and we write on the woman antenatal card her EDD, her LMP is written. To organize continued obstetric care and risk assessment, and we have to assess the woman at the first visit only about her risk. Now history taking. What are the important points in history taking? What is gravida? So gravida is the when number of conception, including the abortions, including the site of pregnancy, all pregnancies constitute gravida, including present pregnancy. So we have to write the gravida. We have to calculate her pregnancy status, that what gravida she is. So it is important to write gravida. So short form of gravida is G. We can write G on the antenatal card, and in front of G we write the number of gravida. Suppose if she is having a previous vaginal delivery and one abortion, previous vaginal delivery and one abortion, then what will be her gravida now? From this side, what will be her gravida this time? Two or three? Please tell. 3, because she is having a previous vaginal delivery and then an abortion, and now she is also pregnant. If she is pregnant, then we will include her present pregnancy. So she will be gravida 3. Previous abortion, previous ectopic pregnancy, previous preterm delivery, previous IUD, whatever the previous history, that will include in gravida, and we write G3. Okay. And then parity. How will you calculate para or parity? So parity is number of times a patient conceives and delivered a viable fetus. Okay, viable fetus excluding present pregnancy. Okay, that is parity. So if this patient who is G3 at present delivered, after delivery she will be what para? She was G3 during pregnancy. But after delivery, she will be what para? Fast. Speak. Even if you are wrong, then you should speak. So para 2, because one abortion will not come under para. So after delivery she will be para 2, and during her present pregnancy she is para 1. So we will write a obstetric score in antenatal card. The obstetric score will be of this particular patient will be G3 P1 and L1. L1 is live birth. If previous child is live, then L1, and we can write A1 for abortion. So she is G3 P1 L1 A1. G is pregnant. Gravida means pregnancy, and no patient can be para. Para will not count during pregnancy. It is after delivery or previous deliveries. Other important history like obstetric history we will take during her first visit only, regarding duration of marriage and history of previous deliveries, previous abortions, previous deliveries, what was the mode of previous delivery, whether vaginal delivery or cesarean deliveries. So that history will be taken. And so obstetric history is to be summed up as status of gravida, para, number of deliveries, number of term delivery, preterm delivery, miscarriages, MTP, and living issue. How many living issue she is having. So we have to write the obstetric score on her antenatal card. Then menstrual history is also important. So regarding the regularity of her menstrual cycles, duration of menses, amount of blood flow, first day of last menstrual period is to be noted, and from LMP expected date of delivery should be calculated and should be written. So why menstrual history is important? Whether the cycles were regular or not. Why it is important? That is important because if some woman has irregular cycles or delayed cycles, if she is having history of delayed cycles, then her LMP may not correspond to the period of gestation. It may be a delayed conception because she is having a cycle length of 45 days and 60 days suppose in a woman. So her period of gestation may not coincide with the LMP. The POG calculated from the LMP will be different from the actual POG of the fetus. So in that case, what we consider? How we calculate the period of gestation or EDD. If cycles are not regular, then how to calculate the period of gestation of a pregnancy? Through the ultrasound examinations. So the ultrasound examinations which are done during first trimester, specifically during 6 weeks to 8 weeks, we should consider them very much accurate to calculate the period of gestation. And why it is important to calculate period of gestation? Suppose for a woman, I don't know about her, I am not sure, she forget her LMP. She forgot her LMP, and I am also not aware of her period of gestation. Then what can be the problem? with that. What issues can occur in such pregnancy? Problem which can occur, like we want to, when we are going to terminate the pregnancy, we don't know. Suppose we are going for induction of labor, and if she is a preeclampsia, if she is a diabetic woman, we are going to terminate the pregnancy. So what can happen? There can be risk of iatrogenic prematurity. Baby may be preterm, we are going to deliver a preterm fetus, and sometime we may go till postterm after the 40 weeks also, because we are not aware. So it is the most important thing in pregnancy to calculate the correct period of gestation by LMP if she is sure. And the second important thing to calculate the correct period of gestation is through the first trimester or 6 weeks, 8 weeks ultrasound. It is very much accurate in calculating the period of gestation, and we can rely on the first trimester ultrasounds to calculate the correct period of gestation. Any doubt? So other important things which should be done after history taking are examination, like general physical examination. So head to toe examination about her pallar, icterus, edema or neck swelling, any other important finding. Then systemic examination, it should start with the nervous system, cardiovascular system, respiratory system, and then breast examination. Why breast examination is important? So breast examination is important to see whether she is having a proper everted nipples. Suppose a woman is having a inverted nipple, or there is some problem in the breast, so she may have difficulty in breastfeeding during her postpartum period. So breast exam, or we can discover a lump in breast during this visit, which is she might not be knowing about that. So breast examination for all female which are coming for examination, for antenatal examination or from gynae checkup, any woman which is coming to the hospital, so breast examination should be done, and then followed by obstetric examination. So obstetric examination, what we see is abdominal examination, the tone of the abdominal muscles, presence of any incisional scar. So what is the most common type of scar she may have? Scar of previous cesarean section or scar of previous surgery. So that is important to decide the mode of delivery, to decide or to predict some complication. Examination, during examination we see the scar. What type of scar? Cesarean section, if she is having a cesarean section in the past, what type of scar she may be having? Anybody can tell? Cesarean section scar. Location. So most commonly a scar is low transverse or a phalansteal scar, that is just above the pubic hairline. That is a common type of incision, a common type of scar a woman can have during cesarean section. And uncommon maybe, it may be cesarean section may be done through the midline vertical, that is infra-umbilical midline vertical scar. If she is having some complications during pregnancy like placenta previa, other end placenta, so in such cases, or when we are doing a classical cesarean section, then we have to take this, or we have to make the incision vertical. That is not common, but there we should see the type of scar she is having in her abdomen, or she may be having scar of some previous surgery, like previous laparotomy due to some intestinal obstruction, due to history of myomectomy, history of any other surgery. And other important thing in obstetric examination is skin condition of the abdomen are to be looked for. Fundus of the uterus is just palpable above the symphysis pubis at 12 weeks. So we should know if fundus is just palpable, then pregnancy is around 12 weeks. So it gradually grows. Initially uterus is a pelvic organ. It gradually grows towards the umbilicus, and gradually it comes above the umbilicus, then it becomes a abdominal organ. It comes till the upper abdomen also. So vaginal examination, so routine per vaginal examination is not indicated, but a per speculum examination should be done, and pap smear also should be done during the first visit of the pregnancy. So blood investigations which are done during pregnancy are hemoglobin, hematocrit, ABORH grouping, blood glucose testing. So blood glucose testing is also important. It should be done right during the first visit only. And screening for syphilis through VDRL or RPR is done. HBsAg status of the patient, HIV status of woman. So these tests are done for all patients. This is the routine that for all women, HIV status, HBsAg status, HCV, and screening for syphilis is done for all patients. And urine examination, urine routine and microscopy to see for any asymptomatic infection. It should also be done. So like serological test for rubella, hepatitis B virus, and HIV antibodies to detect the rubella immunity, and screening for hepatitis B virus and HIV. I already told you that these tests should be routinely done. The other tests like genetic screening through various biochemical tests like dual marker test and triple marker test, they are also advisable, and dual marker test should be offered to all women during 12 weeks of pregnancy. And triple marker test, it can be done during 15 to 18 weeks for mother at risk of carrying a fetus with neural tube defect, Down syndrome, or other chromosomal anomalies. So genetic screening is advisable for all high risk women. Another is the ultrasound examination. So at what gestation ultrasound examination should be done? At what gestation during first trimester? The first ultrasound examination should be done around 6 to 8 weeks. So till 8 weeks, first ultrasound examination should be done. So it gives an idea about the status of the pregnancy, that cardiac activity is there or not, fetal pole, and what is the CRL, what is the exact gestational age of the fetus, and it also gives an idea about the number of pregnancies. She is having a single sac, or she is having a double or triplet pregnancy, and she is not that is not an ectopic pregnancy, it is an intrauterine pregnancy. That is important. So early trimester scan at 6 to 8 weeks, near about 8 weeks, is very important. So first ultrasound examination is done at 8 weeks, near about 8 weeks. Now procedure at subsequent visits. So subsequently, when patient revisit for antenatal examination, then further checkups are done at an interval of 4 weeks till 28 weeks, and at an interval of 2 to 3 weeks till 36 weeks, and thereafter weekly till delivery. Now, objectives of further antenatal visits are to assess the fetal well-being, to assess the lie, presentation, position, number of fetuses, to assess the development of anemia, preeclampsia. By ultrasound, we can see about the amniotic fluid volume, about the fetal growth, whether the fetus is growing well or not. To organize specialist antenatal clinics for patients with problems like cardiac diseases and diabetes. To select the time for ultrasonography, amniocentesis or chorionic villus biopsy when indicated. So these are the invasive tests like amniocentesis and chorionic villus sampling that is done in some indicated patients when we know that a woman has a high risk of some genetic problem. A woman in which fetus may have some genetic problem. How we know? By the soft markers. Soft markers are the markers which are seen during the ultrasound, and the other by the abnormal biochemical test, abnormal dual marker test or abnormal triple marker test. So if a fetus or if a woman has abnormal test of ultrasound or dual marker or other biochemical, then these women may be offered amniocentesis and or chorionic villus sampling. These are invasive tests in which we study few cells from the amniotic fluid or cord blood, in which we study the fetal cells, and we can know about whether this fetus has a genetic problem or not. So these are not routinely done, but when indicated, these invasive tests are also done. So during each visit, we take the history about appearance of any fresh symptoms like headache, dysuria, and date of quickening, examination. So examination, in general examination, in each visit, what we see about the weight. We take weight of the woman, whether there is weight gain or not. Suppose if there is no weight gain or there is weight loss during pregnancy, or there is no adequate weight gain, then what does it indicate? So there may be fetal growth retardation, that pregnancy may have low amniotic fluid or oligohydramnios. So this type of pregnancy may be a high risk pregnancy, or there may be intrauterine death of the fetus. So there should be weight gain. What we see at every visit, weight gain, and pellar we see for all these signs like pellar, icterus, edema. So these are important. Then edema. So edema, if it happens, is it normal or not? It is physiological. There is physiological edema. What is physiological edema? Physiological edema is the swelling of the feet of a woman, especially during third trimester. So it happens during later months of the pregnancy, and it disappears after taking rest, or it becomes less after taking rest. It is due to the compression of the inferior vena cava by the growing uterus. So there is hampered venous return of the limbs, lower limbs. So there can be edema, little edema of the feet that is normal during pregnancy, but it may be pathological also. So we have to see, we have to examine all the women that edema, amount of edema, and edema may be a sign of other problems like preeclampsia or hypertension. So we have to examine, or we have to note all these findings. And blood pressure. So blood pressure is taken during each visit, initially during first visit, and after that every visit. What we have to take? First of all, weight, BP. So BP is such an important thing for a pregnant woman that a normotensive woman may become hypertensive during pregnancy. So we should not forget to take blood pressure of a woman during any of the visit. It can be life threatening for a woman. So blood pressure should be checked. It should be written on the antenatal card that BP has been taken, because these disorders are very, very common during pregnancy. So blood pressure is taken during every visit. And then abdominal examination, inspection, palpation, auscultation, these are the broad headings in which we do abdominal examination. Inspection about the abdominal enlargement, and there will be pregnancy marks, and palpation to note the height of the fundus, whether the fundus is growing appropriately or not. And in the second trimester, to identify the fetus by external ballotment, fetal movement can be felt, palpation of fetal parts, auscultation of fetal heart sound. So fetal heart sound can be auscultated with the help of stethoscope after 20 weeks of pregnancy. So auscultation is also done. In the third trimester, abdominal palpation will help to identify the fetal lie, presentation, position, growth pattern, volume of liquor, also any abnormality. So after second trimester, in third trimester, we also want to know about the lie of the fetus. What can be the lie? Transverse lie or longitudinal lie. Most common type of lie is longitudinal lie. So that we want to know. And presentation, cephalic presentation, breech presentation. So that we make out by doing all this examination about whether fetus is growing properly or not. You people come to the clinic, to the gynae department, then you know how to do the per-abdominal examination. You should do, every time you come to the clinics, you should see how a per-abdominal examination is done. What is the different type of lies, how presentation is felt, cephalic presentation, breech presentation, then you can understand these things. Now examination also helps to detect whether presenting part is engaged or not. The girth increases by about 2.5 cm per week after 30 weeks. So abdominal girth can also be taken, and fetal activity is also recorded, fetal movement, and vaginal examination is not indicated for all the women. It is indicated if you think a woman is in labor, she is at term and she is in labor, then per vaginal is done. Otherwise a per speculum can be done if she is complaining of bleeding or leaking, not per vaginal. So women should be informed of various warning signs like leaking from the vagina, vaginal bleeding, abdominal pain, headache, visual changes, decrease or loss in fetal movements, fever, vomiting, diarrhea. So all these, if she is experiencing such symptoms, then she should consult with the hospital or doctor. So various advices are given, like importance of regular checkup to maintain or improve the health status of the woman, and to improve the psychology and to remove the fear. And increased calorie requirement. Women should be counseled about, she needs some extra calories, extra 300 kilocalories per day during pregnancy. So pregnancy diet ideally should be light, nutritious, easily digestible and rich in protein, minerals and vitamins. So a complete wholesome diet should be there. Dietetic advice should be given with due consideration to the socio-economic condition, food habits and taste of the individual. So supplementary nutritional therapy, in which the most important is iron supplementation, because there is need of extra iron during pregnancy and delivery. So after 16 weeks of pregnancy, extra iron, or what we called as a prophylactic iron supplementation, should be taken by all women, not during anemia. It should be taken by all women. Extra 60 milligram of elemental iron should be taken. So counseling regarding the hygiene is also given, like adequate rest, adequate sleep, bowel, bathing, clothing, dental care, care of the breast, travel, avoid smoking and alcohol. So all these advice should be given. And about the immunization, so all live virus vaccines like rubella, measles, mumps, varicella, all these are contraindicated during pregnancy. And hepatitis A, B vaccines, toxoids can be given in pregnancy also. And what immunization is done or given routinely? Tetanus immunization. So nowadays we give TD. What is TD? It is tetanus and diphtheria, that is reduced diphtheria toxoid. So that is given. TD is given ideally in during the first visit, and the next after the 2 doses are given, next after the 4 to 6 weeks of first dose. So TT or TD is given. TT is tetanus toxoid and TD is tetanus and diphtheria is given. And in some countries or outside India, they give Tdap, that is tetanus, diphtheria and acellular pertussis also. They are giving to the pregnant woman Tdap. What we give is TD, that is tetanus and diphtheria. So 2 doses are given, which is given intramuscularly 0.5 ml. And general advice that she should be warned about some warning signs, and she should report to the hospital of during any warning signs. So a little about preconceptional counseling. So preconceptionally also women should be counseled about any risk factor and to eliminate the risk factor in an attempt to improve the pregnancy outcome. And virtually preconceptional counseling is a part of preventive medicine. So preconceptional visit, it consists of identification of high risk factor, base level health status, rubella, hepatitis immunization, folic acid supplementation should be started before pregnancy. Why it is started? Folic acid. It is started to prevent the development of neural tube defect in pregnancy. So it is started before pregnancy, folic acid. And maternal health is optimized preconceptionally, fear of incoming pregnancy, patient with medical complications, drugs used before pregnancy. So some women may be taking some drugs which may be teratogenic. So most problem occur during the early fetal development, like during the first trimester itself. So if she is taking a teratogenic drug or any medicine, she should consult before planning pregnancy, because many drugs, X-ray exposures, they may be teratogenic to the fetus. And women should be counseled to stop smoking, alcohol and any other drug intake. And inheritable genetic diseases, importance of prenatal diagnosis. So these are the investigation. Any questions or queries? Anybody ask to want some question? So this was about the routine advice or routine investigations which we do and how we do antenatal care during the antenatal visits. Roll number 1. One is absent. 2, 3, 4, 4, 5, 6, 7, 8, 9, 10, 11, 12. Who's 12? 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 23. Who's 23? 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52.